Thank you. Thanks for the introduction. I feel on pressure, especially after Johnny's talk, to give you a huge amount of information. And thanks to everybody for your contribution to what is an arduous data collection process. So as you can see, I'm a member of the NELA project team, and we've got some information for you. I just wanted to go a little bit into the background first of all. Now, I know a lot of you will know this, but I think some of it bears repetition. Emergency laparotomy is a commonly performed procedure. The HES data estimates is about over 30,000 a year performed in England and Wales. It carries a substantial morbidity and mortality. Some of the prior studies, which I'll go into in a moment, show 30-day mortality historically has reached about 15%, and that rises sharply over 1 or 2 years. This is a paper by Saunders group. This is the Emergency Laparotomy Network. So this was 1,700 patients from 19 units. These were the enthusiasts. So even within this group, there was a tenfold variation in outcome between the best and the worst performing units. And this was published in 2012. Omar Fayez's group did a similar study, but looking at HES data, again, outcome following emergency laparotomy, and they showed a 6-fold variation in outcome. Now, neither of these studies are perfect. HES data, as we all know, has got its inconsistencies and problems. And the group, the previous study by Saunders et al., this is non-risk adjusted data. But even if the actual variability is even half what was shown in these studies, it's clearly far from ideal. I'm speaking to general surgeons, and I'm sure all of you will be au fait with these group of documents from the Royal College, Department of Health and our specialty associations. And these all were published over a few-year period, some years back, just really trying to streamline the care for patients undergoing emergency laparotomy. And it's really about providing a robust service for all patients, not just when things are quiet. So what does it look like? Well, these cases need to be prioritised over elective surgery, which has not historically been the case. You need to be able to get them into theatre quickly. And as units continue to have difficulties with, you need to have 24/7 access to essential resources, particularly interventional radiology and endoscopy. There have been some defined timelines set out for how we should be treating these patients, and senior-led service is key to this. Assessing risk of death beforehand, I'll go into a bit later, but we believe is key, and making sure that those who are higher risk get appropriate critical care beds. Underpinning all of this is having better data, and that's hopefully where NELA comes in. So again, I hope that most of you will have engaged with the process already and know what NELA is and be entering the data. But just for those of you who might not know about the audit, it's a nationally funded audit which looks into the care of all patients undergoing emergency laparotomy. This, and I'll say it a couple of times, is not just a data collection exercise. Really what we want, one of the main strengths of this audit, is to provide high quality local data so that units can undertake their own quality improvement. So I'm reporting some of the data from the first year of data collection. And we've got just over 20,000 cases from 192 hospitals in England and Wales. There are some caveats to state at the beginning, and that's that we are still waiting the ONS mortality data. So anything we've got at the moment is self-reported, which does rather limit how much we can report on outcomes at the moment. So I'm just going to go a bit into some of the demographics first of all. This is the age by decade of the total patient group, and is largely what you would expect. We're looking at people in their 7th and 8th decade, largely with the comorbidities that come with that age group who are undergoing this sort of surgery. Operative urgency. This is the operative urgency, the NC-POD classification as set out by the operating surgeon preoperatively. So it was felt that over half of these patients should have surgery within 6 hours. You could argue that those who required surgery within 18 to 24 hours, the so-called semi-urgent laparotomy, aren't really true emergency laparotomies, and some of the analysis that we'll be undertaking later on, we may well exclude this group from the data. ASA grade, again, I don't think there are any surprises here about an elderly, morbid group with abdominal catastrophe. ASA grade of 3 is unsurprising. So why are we operating? Well, Johnny's just done a very nice talk on intestinal obstruction and how to deal with it. Well, a lot of these patients end up coming to surgery. These indications can be entered more than once on the NELA web tool. So that just explains why we've got over 100% in the totality of these. But intestinal obstruction is clearly a very common cause, followed by peritonitis and perforation. Again, there are no great surprises here. Reoperations from a complication of previous surgery are accounting for about 11% of the total. And what are we doing? Well, this is the primary procedure performed. There's space to put secondary and tertiary procedures on the web tool, but this is primary procedure. And again, considering what the indication for surgery is, there are no great surprises here. So small bowel resection, adhesiolitis, by far the most common, followed by colectomies. And again, operative findings in keeping with the preoperative indication for surgery, adhesions, perforation, far the most common. I've been to a few talks during this meeting where a number of enthusiasts talk about using a laparoscopic approach for these patients. It's not common practice, as we can see. So a total of 6% are completed laparoscopically, with an extra 1% laparoscopic assisted. The lap converted to open comprised 6% as well. So what are the big headline statements? We'll talk a bit about the variability, but I think that if we can say one thing, it's that there is substantial variability between units. And that's both in the provision of what we see to be the essential elements of a quality service, but also substantial variability within outcomes. What we can't yet define, and there's going to be a lot of work to do so, is whether there is an association between providing a quality service and your outcomes. What else do we know? Well, we have to be really careful about making any conclusions about self-reported data until we get the linkage to the ONS data. But the raw inpatient 30-day self-reported mortality of this group is 11.7%. The group, the study performed by Saunders et al. In 2012, their raw inpatient 30-day mortality was around 14%. So tentatively, things may be starting to get better. There is a huge quality improvement drive around emergency laparotomy at the moment, and we may be starting to see the benefits of that. So variability, first of all, in what care we're providing. Senior review in a timely manner is key to the appropriate management of these patients, and this is very variable. So where this was recorded, and again, this is not particularly well entered data point on the web tool, but in those patients that we have got the information on, 48% of patients were reviewed by a consultant surgeon within 12 hours. And this was incredibly variable between different units. CT scanning, 80% had a CT performed and reported preoperatively. Again, substantial variability, 57% in some units, 100% in different units. We all know that there's cases where a preoperative CT is not necessarily appropriate and the patient has to go directly to theatre, but it's the variability, I think, which is most interesting. And there's nothing particularly that tells us that CT scanning is performed any more commonly in elderly or high-risk patients. We think that risk calculation is really key to providing a quality service to those undergoing emergency laparotomy. And that's for two reasons. First of all, so that you can adequately communicate the risk to the patient and have an adequate consent process where you and the patient together decide whether they want to proceed with this high-risk morbid intervention, but also making sure that you provide the appropriate care for them in the post-operative period. The risk documentation is very good at some units and very poor at other units. The interesting thing about this is that patients who don't have their risk documented, overall fall into a medium risk category, but they don't seem to be getting access to the same resources as patients who have had a preoperative risk assessment. And actually it's pretty good. So whether you look at a patient and say, my gut feeling is that they are high risk, or whether they have a P-POSSUM estimation, either on an informal basis or a formal risk calculation, we do pretty well at assessing how high the patient's risk of death is. And again, this is what we've taken in the NELA team to call a processogram. These are all different units, and we can't tell you who they are, but this just shows the difference in risk stratification between different units. So 82% of patients arrived in theatre within an appropriate time scale, and this was much worse for those who needed theatre within 2 hours. So we're not very good at getting people to theatre within 2 hours. It's pretty good within 6 hours. And again, just a graphic representation of the variability between different units. What's the headline for this? Well, we're doing a bit better than the anaesthetists. Consultant surgeons present for 86% of laparotomies, and the anaesthetists aren't quite as good as us. That, somewhat unsurprisingly, goes up with increased risk. And again, you've got this substantial variability. So the area in the blue area is the patients who have got both consultant anaesthetist and surgeon present in theatre. And you can see in some units that's less than 25%, and in some units it's 100%. Critical care admission, 60% in total were admitted to critical care, and this is with a group with an average mortality of 11.7%. 88% of high-risk patients were admitted to critical care. And again, there's just this marked variability between different units. And a 23% critical care admission rate for emergency laparotomy. It doesn't look good, does it? So, as I've said, mortality is difficult at the moment. We've really got to wait for the ONS data. There is variability between units, but there's variable case ascertainment. Until we've got the data from ONS, we can't report it and we can't really comment on it. What we can say is that there's increased mortality with increasing age, ASA, predicted risk and urgency of surgery, which is no huge surprise. Length of stay we can comment on. Again, it's this variability. 6 day median length of stay in the best units to 30-day in those who may be performing less well. Again, the factors that predict increased length of stay are the ones that predict mortality. And these are patients who have a prolonged post-operative length of stay. And we've classified that as over 20 days, which is the upper quartile of length of stay. And again, you can see this substantial variability between units. Unplanned reinterventions is another outcome measure. And again, both with returns to theatre and returns to critical care, we're seeing variability. These groups have a higher mortality, and in those who are having higher rates of return to theatre and critical care, you've got a group that you're potentially failing to rescue. So there's a lot more work still to do, and a lot of this is key on us getting the ONS data. But what we want to try and flesh out is whether providing the elements of this high-quality service do impact on outcomes. Does consultant subspecialty impact on outcomes? We hope to be in a position to give you more information on that in 6 months or so. Our risk adjustment is not yet perfect for this heterogeneous group. So there's again some detail to be worked on. This is a huge data set, and even if you take one of the procedures such as Hartmann's, there's a huge amount of information to be gained from that group. So we're working with the specialty organisations to split up some of these into particular working parties, again, which is ongoing. So NELA is not just a data collection exercise, though it may feel like it at 3 a.m. Tentatively, with the quality improvement, we may be seeing improved outcomes. There's certainly been a huge raising of awareness. Some of you will be involved in the EPOC trial, which is, again, about quality improvement in emergency laparotomy. If you've assessed someone's risk, you can access, makes the process of requesting a critical care bed easier. And in the next few months, different units will be able to access their own data on the NELA web tool for local quality improvement. Thank you.